You're about to experience Healthline, a show where doctors from 𝗥𝗲𝗹𝗁 interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome. Hi, everybody. Thank you for joining us on Healthline with 𝗥𝗲𝗹𝗁. I'm your host, Nicole Jacinto, and today our topic on the show is arthritis. We have with us Dr. 𝗛𝗛𝗵𝗹𝗆. She is a rheumatology specialist. And you are listening to us, by the way, live on DZRJ 810 AM, Radyo Bandido, all over the Philippines. And if you're watching us on Radyo Bandido TV, thank you for tuning in. And of course, you can also catch us on the station's YouTube channel and on free-to-air channel 29. Okay, and I know this show is going to be viewed at other times in other places all over the world at different times. So thanks for joining us for all of those times that you visit the show and you listen to us. And today should be a very interesting topic. I'm sure the doctor will answer all our questions. So if you're tuning in live now, if you're viewing live, please send in your questions during the show so that the doctor can answer them. Good afternoon, Dr. 𝗛𝗃. How are you today?
Hello, good afternoon po.
Hello, good afternoon. How are you today, doctor?
I'm good. How are you guys?
Oh, okay. Thank you very much. I do have a lot of questions for you, and some people might have some questions, some listeners or viewers, so we'll wait for those. But in the meantime, before we start the show, I'd like to say hello, by the way, to Mitchell, who is visiting the Philippines and visiting Manila from San Francisco. I'd like to say hello to Susanna in Hong Kong, and to Lynn watching from Hong Kong, and also I'd like to say hello to Alessandra of Madrid. And I'd like to say hello to Tata. Tata, I love you so much. Thank you for watching the show. And I'd like to say hello to Mommy. Mommy, thanks for tuning in all the time. My #1 fan. Okay, doctor. Okay, so we're going to talk about arthritis today. Can you tell us what exactly is arthritis?
Okay. Well, arthritis is generally a generic term, a general term that tells us about the joints, or joints, or kasu-kasuan in Tagalog. When we say arthritis, there's inflammation or pamamaga ng mga kasu-kasuan or of the joints. So it's a generic term that actually describes the status of the joints. It doesn't pertain to one single disease entity lang.
Okay, so generally arthritis, because it's inflammation of the joints, just the joints, just the joints. Okay, it doesn't, as you said, it doesn't pertain to just one entity. What are the different types of arthritis, doctor?
Oh, there's a lot. So,
okay, what are the most common types?
Yes. Okay, so we can actually probably limit it to the more common ones that our patients would probably usually consult the doctors with. Usually, where the more common ones would be, number 1, osteoarthritis. Number 2, one of the more common ones that we probably would hear from time to time, gout or gouty arthritis. And then number 3 are the immune system problems, or arthritis that's caused by immune system problems, like rheumatoid arthritis.
Okay. So, rheumatoid arthritis. Okay. So, doctor, you mentioned 3 types of the common types of arthritis. When it's osteoarthritis, does that have to do with the bone?
Oh, yes, technically. Technically, it actually just pertains to a kind of arthritis wherein the cartilage, the lining of the joints, usually how we translate it to Filipinos or to our kababayans ay yung kalso that actually protects the joints. They get to degenerate over time. So they get to be broken down over time. So when the cartilage gets to be destroyed or broken down, it usually results to osteoarthritis.
Okay. And of course, in Filipino, usually we just say rheuma, di ba?
Yes.
Get it everything, arthritis or rheuma. Okay, so osteoarthritis means that the cartilage has broken down or been worn off over time. But can it occur at any age?
Or is there any particular age? What's the demographic, at least that you've seen, or that your practice tells you, where it occurs most often?
For osteoarthritis, usually the risk increases with age. However, it doesn't naman say that if you're not old, you don't have like the chance of getting osteoarthritis. There are also other risk factors that make one person, even if they're of younger age, to be more prone to osteoarthritis. Pero usually, that's what actually we associate as rayuma ng katandaan. So that's usually that pertains to osteoarthritis.
And since it's with cartilage, doctor, the cartilage that breaks down, the parts of our body, like, is it possible to get arthritis in your ear because it's made of cartilage, or things like that, or no?
Well, technically, it's really the joints, but your body, remember, is made up of a lot of joints. So that could actually, osteoarthritis can affect from your neck down to your lower back, your spine, that what I meant with that, your hips, your knees, your hands. So all of those are actually joints, which can actually also undergo degeneration and would actually be prone to osteoarthritis.
Yes, and we have a lot of joints in our hands, our feet, no, the small the small bones and joints that we don't often think of until it hurts. We're like always, massaging my feet, there, my toes or my hands. Okay, so thank you for clarifying that, doctor. As for gouty arthritis, can you tell us more about that?
Okay, so gouty arthritis, well, we actually came from the root word arthritis, so there's inflammation of the joint, but it actually is coming from another region. So when we say gouty arthritis, this is actually usually caused by elevated uric acid. So yun yung mga naririnig mo from time to time. Generally, other patients would actually tell you, oh, may namamagang buto-but, may namamagang joint or namamagang paa because napainom sila ng alak, kumain ng atay balon-balunan, mga ganon. So that's actually more gouty arthritis related.
So you were saying earlier, doctor, just to clarify, and please interrupt me anytime because I'm just trying to understand it as a patient coming to you and a non-medical professional. It's gouty arthritis is a type of arthritis that results from another, you were saying another joint, but it can affect, sorry, it's a joint that gets affected because another joint is getting affected?
Technically, how can we relate it? When we say arthritis, it's a generic term. So when we have arthritis, you have inflammation of the joints. When you have inflammation of the joints, that's actually the next task for us is to identify what's the reason for the arthritis or what's the reason for the rheuma. That's actually my main job, which is to know where it's coming from. A group of patients would have osteoarthritis. A group of patients would actually also have a gouty arthritis. So they usually actually would cause kind of the same symptoms. So masakit yung joints, namamaga yung joints, but the cause of it, they actually would differ from one patient to another.
Okay, that's it. The cause would differ from one patient to another. And
yes,
when we hear about gouty arthritis, or we used to just say gout, it's more in the foot area that you'll see like a swollen ankle or foot or something. And as you said, it's more due to like uric acid, a high amount of uric acid in your blood, and that's when people say, oh, because I went out, I drank, I had beer, and then I also ate peanuts and the chicharron or whatever it is, and that can happen at any age.
There's generally a predisposition, just like osteoarthritis. We talked about osteoarthritis earlier. They usually would affect the older generation or the older age group. For gouty arthritis naman, they also would affect a certain age group. For men, it's gonna be middle-aged men. For women, it's gonna be the post-menopausal women or yung mas matanda. So there's also a certain age group that makes that actually has a higher predisposition for gouty arthritis. Later on, siguro, maybe we could talk about the food. I heard
Yes,
earlier
yes,
that you were
later on. We'll
mentioning
circle
about
back
the food.
to the causes
Yeah.
or you're saying predispositions, like how can you be predisposed to it, or what are the risks, if like what makes you riskier or a more likely candidate for having these types of arthritis. And the last arthritis that you mentioned earlier as a common type is the immune system arthritis or the rheumatoid arthritis. Can you tell us a little bit more about that?
Okay, so rheumatoid arthritis is just one of the arthritis that's actually caused by immune system problems. There's a few more, but maybe as one of the main ones, we can talk about rheumatoid arthritis. So when we see rheumatoid arthritis, it's a kind of arthritis. Just like before, we can go back to the generic term or the general meaning of arthritis. There's inflammation or pamamaga of your joints, but the cause is different. So unlike osteoarthritis, that there's wear and tear of your joints, unlike gout, wherein there's high uric acid, rheumatoid arthritis naman, on the other hand, actually is caused by your immune system going haywire or nagkakaroon ng defect with your immune system that your body fights off itself, that akala niya, kalaban niya yung sarili niyang katawan, that actually produces this arthritis or yung pamamaga or swelling of your joints. So, they can actually could give off the same symptom, namamaga, sumasakit yung joint, but the cause is different.
Okay, so the cause is different. And so it's an immune, basically, if you're a patient and you have rheumatoid arthritis, it's because of as you said, your immune deficiency going haywire. So it's not the same, I know, but it's kind of like an allergy when your body overreacts and it's fighting something that it's not necessarily bad for you, but because of that there's swelling, because with allergy, like your face is swollen, things like that, but this one, it's your joints get swollen, and then
so
that causes the pain.
Actually, you got the idea that your body is actually problematic to a point that it actually evokes a response. But the difference now with allergies from autoimmune problems, allergies, yung kalaban ng katawan mo is your environment.
Yes.
Whether it could be pollen, it could be dust, it could be grass, it could be feathers, animal dander. For rheumatoid arthritis naman, it's actually not the environment. The body, it's the self. So it's actually anti-self. So your body thinks that your body is a kaaway, an enemy. Parang nagkukudeta in how we explain it to patients is kind of your body nagkukudeta. So it's fighting off itself, that actually it evokes a certain response from your body, which eventually will lead to your joints being inflamed.
So as you said, your body is self-harming without realizing it, because it thinks your own body, something in your own body is dangerous for your body. And then they're trying to stage a coup and a mutiny. And this is what happens. You suffer because of the pain, because your joints start swelling. Do you find that rheumatoid arthritis is, you can, I'll ask you how you can differentiate and detect it, no? But do you find that it's a bit more common do you see it in younger people? More, or maybe more or the same as older people?
Just like osteoarthritis and gouty arthritis, there's a certain age group that actually makes one predisposed to having rheumatoid arthritis. So there's an age group, particularly for women, that actually makes them more prone. So in a sense, they actually are younger than the ones that we expect for osteoarthritis. Pero hindi lang naman siya it's not only the age that actually is a factor. There's a lot more risk factors like hereditary, genetics, as well as your general well-being.
Okay. Doctor, how you've told us how we differentiate osteoarthritis from rheumatoid arthritis. Can you tell us if the symptoms are different aside from just pain? Is it a certain type of pain, or does it occur at a certain time of the day that or after
Yeah.
eating? Can you tell us a bit more about that? Like pag osteoarthritis, when does it usually happen? And what kind
Mhm.
of pain does someone feel or where? And when it's rheumatoid arthritis, on the other hand, like, is it a kind of certain kind of pain, or what joints? If there's anything like that that you can differentiate.
Yeah, so that's a good question because that's how actually that's also another basis. The number of joints, what joints are affected, when does the pain occur? Those are very important details for us physicians that would actually make us think what arthritis one has.
Mhm.
Um so generally, like going back again, when you have arthritis, usually there's pain in your joints, there's swelling, there's inflammation of your joints. The difference between osteoarthritis and rheumatoid arthritis is usually the joints that are affected. There are certain predisposed joints for osteoarthritis, while there are also other joints that are more commonly associated with rheumatoid arthritis. For example, osteoarthritis would actually generally affect your weight-bearing joints, like your hips, like your knees, while your rheumatoid arthritis would actually more affect bilateral smaller joints. That would mean your hands, your wrists, your elbows, your shoulders, your ankles. So not necessarily weight bearing. In terms of pain, there's also the quality of pain or the characteristic of pain. They actually usually differ. Usually for osteoarthritis, the pain comes in after activity. Like when you use the knee too much, you went up a hill, you went out for a vacation, you walked or actually used your knees and your hips a lot. That's when the or after activity, that's when the pain starts to kick in. While in rheumatoid arthritis, very characteristic is that usually you wake up in the morning, your hands are already inflamed, even if you just rested the whole night. And then the pain actually would take a longer time to subside. Usually with osteoarthritis, the stiffness, usually when you move your hands or your knees, the stiffness gets to be recovered, or at least it gets to be resolved after a few seconds, minutes. While in rheumatoid arthritis, it could actually be prolonged. The swelling, the pain could be prolonged for 1 hour, 2 hours, and it usually would be in the morning.
Okay. So yeah, if you could be osteoarthritis if you walked up too many stairs, or you walk uphill, or walking downstairs, is
Yes,
that also a sign of like knee pain from walking downstairs? Is that a sign of osteoarthritis? It could be. And then whereas
it could be.
could be, how about you mentioned weight bearing joint, so that would
Yeah.
be, like you said, your hips, your knees. And for the rheumatoid arthritis, it would be more of like your hands, things that don't really bear weight unless you're lifting a
Yes.
lot. But but still, that was your arms, no? Not the okay. So like grasping, maybe having a hard time um
Yeah.
holding things, the pain is there. When you
Holding
wake
the
up,
utensils.
holding utensils, okay. Or ball pens like this one, I'm old school. And then um all of that stuff. Okay, so that's a good way also to tell. And as you said, it also, like when you interview a patient, it helps you figure out what type of arthritis it is, whether it's osteoarthritis or rheumatoid arthritis. So those are some differences in terms of the symptoms. And you did mention already the differences in terms of the causes. Like one is through the wear and tear, if we're focusing on the two, and the other is through because of an immune system problem, essentially. Doctor, how about, okay, I've heard of arthritis. Just throw it out there first. Like I've heard of arthritis in the jaw. No?
Oh yeah.
What do you classify that under? Is that a different kind of arthritis altogether? Is that through wear and tear? Or I've heard of
Yeah.
like strange place, oh, do you have arthritis in your jaw? What? People don't normally think that, no? It doesn't
Yeah.
come.
So yeah, generally we have to remember that your body is made up of a lot of joints. So that's your jaw is at your TMJ, temporomandibular is a joint by itself. So there's a lot of other yeah. So there's a lot of other kinds of arthritis that can actually have an effect on it. Rheumatoid arthritis can have an effect on your jaw or your TMJ, and also other kinds of arthritis. Even osteoarthritis can affect your TMJ. So it actually since it's a joint, we have to
Yes.
remember that it can actually be affected also.
Yeah, like, oh, I ate too much during my lifetime, and now it's worn down, or or oh, that's where it decided to manifest the rheumatoid arthritis. But yeah, because I mean, just for some people who will, I've heard you can get there's arthritis in the jaw, there's arthritis in like all sorts of different places. You did mention earlier there are many kinds, and they can affect because the body is made up of joints. But we are talking, of course, about the most basic ones, the most common ones that many people, especially Filipinos, experience. And then, Dr. Estrella, in terms of how do you test for arthritis? Because you were mentioned before we get to the prevention, the treatment, and the care. How do you're saying part of your job is to figure out what kind of arthritis it is. So aside from interviewing patients and noticing these symptoms, well, okay, so how would you go about it? If I came to you and I said, I have pain here, 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 and here, how would you be able to diagnose me? How do you get to diagnose arthritis?
So usually when a patient comes in the clinic, I would yes, we usually start with interview, with history taking, and then we go with physical examination. I usually would ask a lot of questions. So you would find rheumatologists to be very makulit, very inquisitive, very curious about what you're feeling. I usually tell my patients that I need a little bit more of patience and for them to specify their symptoms, because majority of the patients that we see in the clinic are in pain. So with the pain, how will we be able to understand more about it is for the patient to explain what kind of pain, what's the sensation of the pain, where is the pain located, how how severe is the pain, and when would the pain be precipitated or aggravated by those are a few concepts or a few questions that would actually very much help us. After history taking, we usually get already an idea what the patient has. Then we proceed to a physical examination. So expect your rheumatologist to be palpating you, asking you to do certain maneuvers, certain range of motions, asking you to raise your hand, do certain actions. And those are all because of all in the hope of trying to find out what's wrong with you, what's inflamed, what's not, are there any deformities and any limitations. Generally, so when we do palpation, we do range of motion exercises together with our examination and your physical and your history taking. That's when we try to figure out or at least get an idea of what test should we ask for.
Okay, so that's great, doctor. You outlined it. I'd like to emphasize this to viewers and listeners that the first thing you do is interview, no, and you take that's what you call taking the clinical history, no,
History, yeah.
like history and patients, and maybe also their caregivers, who can be there to remind them that, oh, by the way, this is when you complain. As you said, baka makulitan sila. Rheumatologists tend to ask more questions, but you need that information to be able to tell what kind of arthritis it is, and like as you said, what type of pain. Is it sharp? Is it dull? Is it aching? You would ask maybe some questions like that. How, on a scale of 1 to 10, what is it? I'm like 11. Anyway, on a scale of 1 to 10, is it painful right now? Oh no, it was more painful this morning. You have to go through this. So it's like always, like what I notice with doctors is you have to be detectives. And I like it when the doctor asks a lot of questions, because it tells me that the doctor is really trying to find out. So if there are doctors like Dr. Estrella here who ask you a lot of questions, audience, you should appreciate that. because that means they're really listening and they want to know before jumping into other types of testing. So when you've gotten the patient's history and you maybe ask like, what time do you get it and all of that, or after you've eaten this, do you get it? And the patient will
Yeah.
also maybe have a good time, not a good time, but find it a sense of relief opening up to you. Like, I ate this, then it hurt. I did that, then it hurt. After you take the history, you said you can also then decide what other tests to administer. No, what would those other tests be? Are there diagnostic tests that you take with machines in the doctor's office, or other? Sorry, palpating. You said so. It's a physical exam. So you could ask the patient to bend down. I can't touch my toes, whether or not I have arthritis. Can't do it. But others, no, you might ask them. You said range of motion. So would it be like you ask someone to move their shoulder, or can they raise their hand up? What do you think of frozen shoulders? Does that have anything to do with arthritis, by the way?
Yes. Frozen shoulders are actually also can be consulted to a rheumatologist. There's a lot of factors that actually have would cause your shoulders to be painful. So that frozen shoulder, we get to assess it usually also from history taking, from physical examination. Patients are unable to do full range of motions with their shoulders. So just to highlight the point that yes, good physical examination is also very much warranted and is expected from a rheumatology consult.
That's okay. That's great, doctor. So, I mean, if you go to someone who is not like Dr. Estrella, so, and will be just like, okay, sure. Nah. You go to Dr. Estrella na lang, or Dr. Estrella would recommend. Okay. And what are the other tests that you would take after that? Are they blood tests? Are they other types of diagnostic tests? Just so the audience knows, it's not that complicated pala to go and get checked, because many of us are afraid to go and get checked.
Yeah. So generally, the after physical examination and our history taking, we are already able at least to get at our top considerations for what a patient has, and from there on, we actually ask the patient to do some few tests. Things that actually the patient could expect would be blood tests, and or imagings. So when we say imagings, it could be X-rays, it could be CT scan, or it could be MRI. So those are just some few tests. It's hard to generalize the test that we could do for the patient, because it's a lot. But if we're talking about osteoarthritis, usually we ask for imagings like X-rays. While for rheumatoid arthritis, it's gonna be a combination of your imagings like X-rays together with your blood test.
Okay. Yes. I was told once that rheumatoid arthritis you can tell from taking a blood test. So you're saying now that if it's rheumatoid arthritis that you suspect, you would probably take a blood test and some imaging meaning X-rays or CT scans or MRIs. And if it's osteo, you might ask more of imaging, whether it's X-rays, CT scans, or MRIs. Can you tell me why is the blood test significant for the osteoarthritis? The rheumatoid arthritis. What can you see in the blood that would tell you that somebody has rheumatoid arthritis?
When the patient has rheumatoid arthritis, going back to our definition earlier, there's something wrong with the immune system of the patient. So there are antibodies actually that's present in the blood that would make the patient or generally cause the disease itself. So we could actually get for those particular antibodies together with your usual blood tests like your CBC, some acute phase reactants, wherein we can know if the patient has a high level of inflammation, like your ESR, CRP. So those are just some few blood tests that we could actually ask for a patient with rheumatoid arthritis.
So if somebody went to consult you, and let's say they did their lipid profile or a SPEC 23, and then they said, okay, so I have pain. You might order extra tests, like,
Mhm.
um, well, the CBCs all include there, but you might order extra tests that are specific to test for the antibodies that you can see in the blood if they have rheumatoid arthritis. And you
Yeah, so these tests are not technically part of your routine test, not part of your Spec 23 definitely. So these are tests that we actually ask for in addition to your basic routine test.
what does ESR mean, doctor, and CRP?
Oh,
Those are
they're they're generally called acute phase reactants. They actually would signify to us doctors if there's a high level of inflammation in the body. So if the patient has rheumatoid arthritis, we kind of expect it to be elevated also. So those are just some markers that
yes,
could help us actually like puzzle pieces
yes,
that will help us determine if the patient are is or has rheumatoid arthritis.
or has like some immune system uh deficiency, or I don't know what you call it, that shows you, I mean, that is present when you have rheumatoid arthritis. So that, okay, so it's that simple. No, you just take the blood and then the imaging. Of course, do you image parts that have you ever had a patient who's come in and has had every single part or possible joint aching, and has had a
Yeah,
combination maybe of
yeah,
osteo plus rheumatoid plus.
yeah.
Mm.
So, well, I definitely would have a lot of patients coming into the clinic, doctor, everything, like lahat masakit. That's why we usually take our time doing history, doing physical examination, because that's where you will be able to pinpoint what particular areas really are masakit. Otherwise, if the patient usually kasi is in pain, they usually tend to generalize it. When the patient's in pain, that's a discomfort that they don't patients don't usually think about it. Oh, this particular part lang masakit. Most of the time they would say, oh, the whole leg is masakit or the whole body is masakit. That's why we do a thorough physical examination and history taking. That's where in which that would help us pinpoint whichever part of the body is really um that's really affected. In terms of imagings, we don't necessarily do an imaging for the rest of the whole body
Mhm.
unless it's indicated. There are a few parts of the body that actually are more commonly affected. Like for rheumatoid arthritis, we usually ask for an imaging of your hands, of your
Mhm.
wrist, sometimes of your knees.
Mhm.
While for osteoarthritis, we usually ask for x-rays of your knees, your hips, the ones that are pretty predominantly affected.
Sounds like that. It reminds me of that song when you're in nursery. You're like, you're my hands, my knees, my shoulder. Or what? I'm not singing it in the right order. But yes, okay. Thank you for that. For that great explanation and clarification, doctor. And also, about pain in arthritis. When someone has arthritis, is there a referred pain? Do
Yeah.
they experience that also? Like, di ba, let's say you have a toothache and it's in your upper right tooth, but then you think it's the lower right tooth that hurts because there's referred pain. Does that happen also with arthritis? Like it's actually your knee, but it hurts in your ankle or another, or the bone in your leg or something like that. Does that happen also?
In a way, it actually can happen. Like for your when you have, for example, when you have your knee arthritis, it could actually would have some pains on your thigh, on your hips also, because um your body tends to compensate. So when your one part of the body is not able to function well, the other parts of the body tend to compensate, and they would actually cause or would be affected also in a way. So, referred pain in a way can also be associated or expected in patients with arthritis.
Yeah. So, you're that's great. You pointed that out again. No, na, let's say your arthritis is in your hips or knees and the other part hurts also, you're saying the body compensates. So it tries to find the most comfortable position, or maybe when you're walking, it's carrying that extra weight. Like automatically your body does that, no? Okay, so then that part might also get affected or be in pain, not because that part also has arthritis, but because it's trying to make up for the other part of your body that it's helping, essentially, or supporting. Okay, doctor, we just have to take a short break. But when we get back, folks, we're going to talk about prevention, treatment, and care. And maybe some of the risk factors, or maybe even how you treat arthritis. All of these questions, and if you have any questions, as we say on the show, you've got questions, we've got answers, and certainly Dr. Australia here has the answers for you when it comes to arthritis. So stay tuned. We'll be back in a couple of minutes. Okay, Dr. Australia, don't go anywhere. I got more questions for you. I'm a more makulit patient, more a makulit doctor. Hang in there. We'll be right back.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. 𝗛𝗶𝘁𝗵 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable through Makati Med Care Access at 𝗥𝗲𝗽𝗶. Available for outpatient care services, our 𝗥𝗲𝗽𝗶 site offers consultation and diagnostic procedures such as medical assistance, hospital admission assistance, blood pressure monitoring, laboratory tests, and X-ray, among others. This is really convenient for those residing in Makati and nearby areas who do not want to go to the hospital to have these treatments and procedures done. We believe that access to excellent quality and compassionate healthcare is a basic human right, and we at Makati Med 𝗥𝗲𝗽𝗶 are doing our best to make this possible to more people. We are open from Monday to Saturday at 8 a.m. to 5 p.m. at the third floor of 𝗥𝗲𝗽𝗶 in Makati City. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Care Access 𝗥𝗲𝗽𝗶.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
How you interview a patient to find out and diagnose it, and what tests you give. Now, can I ask you, doctor, if we go through the top three that you mentioned, or perhaps, yes, the top three that arthritis, the most common arthritis that you mentioned, the osteoarthritis, gouty arthritis, and the rheumatoid arthritis, which is, of course, as you explained to us, related really to the immune system of a person. Can I ask you what you were talking about predisposition? So can I ask you first, what predisposes someone to having osteoarthritis?
Okay. So for osteoarthritis, generally, age is actually a risk factor. Like what we mentioned earlier, it tends to affect the older age group. Number two, genetics can also be a predisposition if you have relatives who have osteoarthritis. Number three, if you have a higher weight, or if one is obese or overweight, that could actually cause earlier onset of osteoarthritis. Number four, if you did have an injury with that particular disease, like a knee injury or a hip injury when you were young, or if a patient is an athlete, that actually makes it more prone to osteoarthritis. Also, what they also found out is the female, the sex of
Yes.
gender, they actually also are more prone to having osteoarthritis.
Okay, when it comes to the females, doctor, is that because you tend to lose your bone density at a certain age? Is that the reason?
That's actually different. That's actually osteoporosis.
Okay, yes.
So that's how brittle the bones are. But yes, for osteoporosis, after menopause of a patient, that makes it more prone. But with osteoarthritis, um, female, they just notice that it actually makes or affects more of the female sex, together with the other risk factors like increased age, increased weight, and history of trauma or injury to that particular joint.
Okay. So just to recap, that's for osteoarthritis. Of course, there's age because it's wear and tear essentially.
Yes.
Factor, and then the I can't read my handwriting. No, okay. Of course, having too much weight, bearing too much weight on your body, being overweight or obese is your joints. Your joints will bear more weight, and then there's also getting injuries. And athletes also, maybe because there's a lot of like use, or I think athletes get a lot of injuries and then they just keep going, no. So and then if you're female, for some reason females are more likely to get osteoarthritis than males. Okay. And also, doctor, when you talk about injury, is it something that it may not have been a big injury at the time? Like, I mean, could it be something like when you were younger in your 30s, you fell in the bathroom and then you didn't realize that you had an injury that got worse over time? Or, a lot of us also, like, I guess a lot of people my age, but I notice a lot of people tend to, like, they get into a biking accident or something, or they fall, and it's not like they're super athletes, or maybe they get bumped in the car, then they get whiplash and they think, oh, it's not a big deal, no? And then they don't
it doesn't have. Yeah, it doesn't have to be an injury wherein you had an operation for it. You don't have to be an athlete to have those injuries or to have wear and tear of your joints. So it could have been an injury from way before. You fell off a bike, you just brushed it off, you limped for a while, but it got better over time. And you did not do any tests for it because it got better over time. So that could actually be a predisposition by itself. It's just that it wasn't diagnosed at that time. And like I told earlier, it doesn't have to be an injury wherein you had an operation for. Any injury for that particular joint could actually make it more prone to having osteoarthritis.
Okay. Just reminding some of my friends out there who, like, those of you who slipped in the bathroom when you were drunk or something, and if it's hurting in the area right now, that may be the reason. Okay. So there we go with arthritis. Those are the predispositions. How about with a gouty arthritis, which is uric acid driven? What are the predispositions or risk factors? Like, what would make someone tend to get gouty arthritis or gout?
So, like I mentioned earlier, that certain age groups and certain sex also are actually predisposed. So for men, it's gonna be middle-aged men. For women, it's gonna be post-menopausal or elderly women. They're more prone to having gouty arthritis or elevated uric acid. Together with that, if you have also, if there are certain lifestyle diet preferences that make that one is fond of, that actually makes them more prone to gout. Like, for example, if the patient is fond of drinking alcoholic drinks, that actually makes them more at risk for gouty arthritis. Other food would include red meat, innards or laman loob.
Mm-hmm.
Those are some of the things that actually make one prone to or to having high uric acid, eventually gout.
Doctor,
Go ahead. Okay, go ahead.
No, sorry, I think I interrupted you.
Sorry. Yeah, but it goes beyond diet. Aside from that, generally, sometimes the body's just wired in a way that the body's overproducing uric acid or under excreting, hindi na ilalabas ng maganda yung uric acid. So that's generally makes them more at risk to having gout.
Okay, doctor. When it comes to females who are postmenopausal and men who are middle-aged, by the way, what's middle-aged now? Can we get a figure around there? I know it is longer, but what is middle-aged now? Can we get a sort of
40, 30 to 4 to 50. That those are usually the age bracket for men that are more at risk to having gout.
Okay. All right. So, doctor, you did say it's very interesting. You said the body can under excrete uric acid that it has in its system. How do we excrete uric acid? Is that through urinating, sweating, or
Yes.
okay? So it's
Majority of it is really urinating it out. But there are sometimes for some patients it's actually defective, or at least they're under excreting uric acid that would make them more prone to having gout or elevated uric acid.
okay. So that's why, and then does it have anything to do with age also? The under excreting. I mean, does that come with age that you tend to under excrete through your urination?
Not necessarily, but if you do have chronic kidney injury, it might actually also be affecting the way you excrete your uric acid.
Yes, okay. And then maybe some of not just the diet, but okay. Well, let's talk about the diet first. You mentioned that alcohol and red meat are two of the main, how shall we say it, yung mga salarin. Of the main things that if you have too much of it in your diet, then it can cause high uric acid. Any kind of alcohol, any kind of alcoholic drink?
Technically any kind, but the worst culprit probably would be beer. But how would what I would tell patients is actually everything could actually cause any form of alcoholic drink could cause your uric acid to be elevated. Sometimes I just don't give that particular information that beer is the ultimate culprit, because at the end of the day they might still end up drinking and just avoiding beer altogether.
Yeah. So I'll avoid beer. You know what? I'll just drink scotch all the way plus gin. But then still, is that because
they're still culprits?
Yes, it's still the culprit. Is it because of the fermentation, or do we know what it is in alcoholic drinks that cause us to have higher uric acid?
Oh, yes. When you metabolize your alcoholic drinks, eventually you produce uric acid.
Oh, so it's a byproduct of
it's a metabolic product when you process this particular food or this particular drink.
And then also for the red meat, is that the same thing?
Yes.
And then how about sorry, go ahead.
So generally, so that's red meat, alcohol, innards, and also sweetened drinks or soft drinks.
Okay, sweetened drinks how come sweetened drinks or soft drinks? Why that?
There's a particular sugar, particularly fructose. When your body metabolizes it, your body eventually ends up having uric acid or producing uric acid pa rin. So it's not a common knowledge for people. Usually they would associate it with alcohol, but yes, sugary drinks and soft drinks could actually be a culprit also.
You mentioned fructose. I may be like wrong or outdated. Fructose, does that mean sugar from fruits, or just like
yes.
But sugar from, and then there's sucralose, which is sugar from sugar.
And so yes, there's a lot of kinds of sugars, but yes, but fructose usually can be are usually more associated with fruits, but they can be actually found we can find them in soft drinks, fruit juices, and other kinds of sugary drinks.
I mean, I think it's okay. I mean, how would you, if I as a patient came to you said, Doc, I'm going to eat a lot of fruits because it's good for me and the rest of my body and my digestion. So that may be okay. But see, if I drink sugary drinks like what I'm drinking now on the side, it says high fructose corn syrup. That's why there's an excess amount of it. Okay. So I just wanted to explain that because I didn't want people to like stop eating fruits. So I would be correct saying, Doc, so you tell me, cut out your sugary drinks because maybe the fruit is fine, this actual fruit, but the sugary drink is not necessary. Oh,
With fruits, all in moderation.
all in moderation.
You
Okay.
can actually, yeah, you can actually allow the patient to eat fruit, but everything in moderation, because at the end of the day, anything in excess would actually be also not good for the patient.
Okay. Okay, so can you do some myth busting? I've been told that eating, let's say, munggo or mung beans or any beans or like vegetables that have beans, does that cause higher uric acid?
Technically, no. In terms of studies that would back it up, there's not a lot of studies that would back up mongo, sitaw, string beans, causing elevated uric acid. However, I would find some patients telling me, Doctora, I promise whenever I would eat adobong sitaw, the next day I'd be limping already. I can well that those are things or some cases that we cannot question. However, if we go back to the studies, those that I mentioned earlier have the most correlation with with uric acid levels.
Okay. So it's not like you can the studies have proven that they really cause higher uric acid, but they do have a correlation and patients experience it. So if you're feeling,
Yeah.
then there's probably something there. How about
It's hard to question what the patient feels, but when they usually ask me if it's really correlated, I go back to what the studies would show. However, yeah, when if they tell me that it really causes some pain for them, then I would tell them to at least eat them in moderation or at least avoid them.
how about soy? I've heard. And so that's also toyo. If you're talking about adobo, toyo is soy sauce, right?
Yeah.
Does that elevate uric acid, like a lot of soy or soy sauce?
Technically not also. And how would I relate it? Probably when you eat a lot of maalat or salty food, you would probably be dehydrated. So the dehydration could cause the flare up or the gout flare up. But soy, to be technical, is not really that much correlated with elevated uric acid.
Thank you for myth busting. So I can eat tofu again. No? How about
Yeah, in moderation.
in moderation, always in moderation. How about peanuts?
Just like peanuts and mungo and sitaw and beans, they're usually um they're usually a myth that our other like lolo lola tita
Yes,
tito
yes.
would tell us. Yes. But
Even
technically not.
technically not okay. Even hopia sometimes because it has a like mungo or something in it, right? Like the beans, they'll be like, "Oh, you shouldn't eat too much hopia," but it's good. Moderation.
Technically not. In moderation again.
Okay. Thank you, doctor, for clearing up and myth busting for us today on the program. Because sometimes you're like, oh my gosh, what other vegetables am I gonna eat if it's good for me if I have to eliminate all these things? Thank you, doctor, for that. Okay. So you talked about the basically what makes you more prone to getting oh sorry, I haven't asked you yet about the rheumatoid arthritis. What can make you've talked about the gout, the uric acid, what can make you more prone or predisposed to getting rheumatoid arthritis?
Generally a genetic history of rheumatoid arthritis or any autoimmune disease for that matter. Like if you have a family history of patients who have rheumatoid arthritis or lupus or any other kind of autoimmune disease in the family, that would make one more prone to having rheumatoid arthritis also. But it doesn't actually necessarily would mean you would have also, but it
Yeah.
just makes you more prone to having one.
Can you name some other autoimmune diseases, doctor? Like, oh, okay, we're making it clear. Doctor has made it clear that it doesn't mean you'll have it, but it could make you more prone. Can you name some of the diseases? Because just so that the other autoimmune diseases, just so that, I mean, somebody can clear it up with someone like you if they feel that they have arthritis, or maybe they're thinking this is pain because I have this one autoimmune disease, but maybe they also have arthritis.
Yeah.
Just for our curiosity.
So aside from rheumatoid arthritis, one common autoimmune disease would be lupus,
Lupus.
SLE or lupus. A few more other kinds of autoimmune disease would be ankylosing spondylitis,
Okay.
psoriasis or psoriatic arthritis,
Mhm.
inflammatory bowel disease. So those are some other kinds of autoimmune diseases that actually all in the realm of autoimmunity or rheumatology.
Okay.
Again, I would like to highlight it doesn't necessarily mean that would have an autoimmune disease if you have a family member who has one, but it's actually a good information to let your doctor know about your relatives who have those diseases.
Okay, so that's good. Yes, of course. Don't panic. It doesn't mean you have
You
arthritis because some of your relatives have this, or the reverse. Like, it doesn't mean you might also have these other autoimmune diseases if you happen to have arthritis. But if your doctor asks you, it would be good to know kind of the family history, or like
Yes.
what's going on. So you call your cousin, what's up? Do you have lupus? Or
Sometimes here in the Philippines, I would ask the patient, meron po bang mga kakaibang um, sakit sa pamilya? They wouldn't actually know if it's autoimmune or not, especially in the province. But sometimes they would tell me, oh, may parang kakaiba po na ang sabi nila, rayuma na nagbabalat, psoriasis po ba to or ganyan. So that would be a technique for other doctors or for other clinicians who would like to ask for autoimmune diseases in the family.
Okay. And that's good. That's why you're asking people that. And of course, they all don't always know. But it would be good kung sakaling alam mo. I mean, maybe you can get the patient can take the initiative to get the information when you ask them, no? May kakaibang sakit. Maybe they can call them or text them. May kakaibang, anong sinabi ng doktor? Ano yung diagnosis? Yeah. Okay, thank you, doctor. So you told us what can predispose us to having maybe 3 common types of arthritis. Can you tell us, can arthritis be treated?
Technically, it depends on what kind of arthritis you have.
Okay.
So again, we'll have to go back to what kind. If this is osteoarthritis, it's technically a progressive kind of degeneration or breaking down of your joints. But what we can do for those with osteoarthritis is to prevent pain, to prevent further progression of the disease, and to alleviate and maintain the quality of life of the patient. So, sometimes I would tell the patient, hindi ko na po mababalik sa binatang tuhod yan or sa dalagang tuhod. But what I could help you is what help I could give is actually to alleviate the pain, to help it from further progressing, and to maintain or at least better your quality of life.
Okay, so basically, if I ask you, pag tinanong natin, magagamot ba yan? Is there a cure? No. Technically, if it's osteoarthritis, but what the doctor can do, what Dr. Estrella can do for you, is to stop the progression so it won't get worse. Hindi maglalala, no? And of course, the patient also has to cooperate with Dr. Estrella in that term, and then also to manage the pain or prevent the pain so you don't suffer, and then also to give you a better quality of life, because we need that.
Yes.
Too many people, I find that too many seniors that I know in the Philippines are just like, oh, well, I'll take it, I'm old na kasi. No, you don't have to take it. You don't have to take the pain. You don't
Can
have
I
to
just
condemn yourself. Sure, go ahead, doctor.
for some patients, we actually, well, if it's needed, sometimes you can actually offer surgical intervention. We refer them to an orthopedic surgeon just generally to assess if they're candidates for a knee replacement. So those are things that we could offer aside from medical
Medicine.
medicines, yeah, and physical therapies.
Physical therapy. Okay, so if you offered orthopedic, like let's say a knee replacement surgery, and that worked, that's also curing it, right? It's not just treating it, but in a sense, it's curing it. Kasi hindi na
Kind
siya.
of, yes.
Okay, kind of, okay. Sige, I'll take the kind of. Naka C plus na ako dito kay doctor at pumapasa pa rin ba? Pwede na? Okay. Okay, so I think like a patient and ask all the questions. So, okay. So, okay. So, kind of, but okay, that can work. Surgical intervention can work for some types of osteoarthritis and upon your recommendation. And then, well, okay, let's talk about the medicine for osteoarthritis. What do you usually prescribe to someone who has osteoarthritis, and do they always need medicine? And when they do, what do you prescribe? What kind of medication?
Usually we start with pain control. The most common ones that we prescribe would be acetaminophen or paracetamol. We could actually also give a group of medication. We call it NSAIDs.
Yes.
Patients would be more familiar with some generic brands like naproxen, 𝗪𝗪, like clofenac. Those are some NSAIDs that we usually give from time to time for patients with arthritis. But it's not for everyone. We usually assess the patient if they're candidates to be given those medications. And some patients, aside from medicine, we could actually give intra-articular management or medicines for.
Okay. Okay, let's go. I'm so glad that somebody said acetaminophen or paracetamol. Yes, doctor. I mean, because the acetaminophen is I'll be the one to say the brand names because people know it. And I know as a doctor, you don't want to be favoring. There's Tylenol in the US and Canada, and there it's acetaminophen. And then sometimes when they sell Tylenol here, it's actually paracetamol, no? And when we're all familiar with paracetamol because I think everyone knows that already, and I don't have to mention some of the name brands. So you could give either of the two, but are there any side effects if they're taking, let's say, acetaminophen or paracetamol every day? If you read on the label, it says that if you take acetaminophen every day, then, it's bad for your liver.
Oh, there's of course, generally with every drug, there's a limit or there's pro and con for every drug. Be it as safe as paracetamol, it could have some side effects, especially if it's taken beyond the recommended dose. Agree. Tylenol is actually also is very famous in the US. Generally they would use generic terms like acetaminophen, but acetaminophen is also paracetamol here in the Philippines. So
change in the chemical structure, right?
Oh, it's actually almost the same. They just actually would differ in the terminologies, but they're of the same molecular entity. Tylenol is available there. Tylenol is also available here in the Philippines. So also there are a few more brand names of paracetamol that you can actually readily get from the pharmacy. Yes. So with paracetamol, it's actually generally a safe medication given that it's being given in the recommended dose. Usually, we don't go over the limit of 2 grams per day. So you would find doctors prescribing paracetamol or Tylenol to be given to as much as 2 to 3 times a day, and that's well within the limit, granting that you don't have any other illnesses in your body like a liver disease.
Okay. And that you're not really a drinker, because then that will just bring things together for the like storm in your liver. Okay. So, but always under the supervision of a doctor like yourself, knowing what to deal with. Okay. And then generally, okay, so when it comes to the NSAIDs, the non-steroidal anti-inflammatory drugs, you mentioned some naproxen, 𝗪𝗪, when do you prescribe that as opposed to acetaminophen or paracetamol?
Generally, there are a few patients who would require NSAIDs given that they don't have kidney problems. That would be one of the things that we would look for. Also, if a patient needs an anti-inflammatory or if the joint is actually inflamed, they would need an anti-inflammatory together with their acetaminophen or paracetamol. So those are some of the criterias in terms of giving NSAIDs.
Do you okay, what if a patient is allergic to
Oh yeah.
NSAID? So
If we shy away from giving NSAIDs, we give other anti-inflammatories. So we have a few more in hand, like your steroids. We could give short courses of low dose steroids. Also, like what I mentioned earlier, an option is that we could actually inject the knee with anti-inflammatories or your cortisone steroid shots.
yes, I hear injections. A lot of people don't realize that they can get injected for certain types of arthritis, or maybe for all, because the steroid will bring down the inflammation. But
Yes.
it's also bad if you just like do it on your own, right, and take steroids thinking that this particular steroid will bring down the inflammation. Yeah.
Yes. Generally, steroids, we want that it is actually being overlooked or monitored by the doctor, especially with the systemic ones. So you have a couple of options. You can actually do systemic or oral steroids. You could actually inject the knee or the joint with the steroid. Injecting the knee or that particular joint with steroid would actually be a little bit more safer because it actually is a localized procedure. The effect of the steroid will be on that particular area.
That's great, doctor. And when it comes to gout, how do you treat it or medicate it, or well, can it be treated? Can it be eliminated or just managed in a sense, like the osteoarthritis?
Okay. With gout, our main concern would be bringing down the uric acid to a certain level. But before doing that, we have to also answer the symptoms of the patient. If the patient is having an acute flare of the gout, we give anti-inflammatories also, and pain control and pain medications. Just like with osteoarthritis, we could give paracetamol, we could give NSAIDs. But beyond that, we have to address also the elevated uric acid of the patient. So you would eventually find doctors or rheumatologists prescribing medications like febuxostat, allopurinol, in order to maintain the serum or the blood level of uric acid low to control this particular disease.
Yeah. And I think I interviewed one of your colleagues maybe a few weeks ago, and I was asking about, I think febuxostat or one of those, and they said it's not, because I asked about the side effects or how it can be bad for kidneys, and they said, well, anything that brings down uric acid is also good for kidneys, for the kidneys. So you would give that medication that brings down uric acid, and would it be permanent, or is there, like, do you try it out for a few months, and if it's brought down, can it be contained? Can pain from arthritis that you get from having too much uric acid in your body, can it be eliminated through diet and exercise or whatever? It's always diet and exercise, but it is.
But usually we would tell the patient, expect it to be part of your maintenance medications. We would titrate the dose from time to time. We could actually increase the dose or decrease the dose of the febuxostat or allopurinol as needed, depending on the status of the patient, status of the serum uric acid. But how we would explain it to patient is that expect it to be part of the maintenance. So that maintenance medication, together with diet modification and lifestyle modification, weight loss, they're all part and parcel in management of gout.
Okay. And then thank you, doctor, and the weight loss. Yeah, why are you looking at me? No, it's true. I need to lose weight. And then, doctor, for health reasons, okay. When it comes to the rheumatoid arthritis, how do you treat it? Well, it's an autoimmune disease, but you answer it. Can it be cured?
It could be managed. Maybe cure is a term that we
strong word.
A strong word. We don't actually give that one out for patients with rheumatoid arthritis. It's actually managing the disease. So when you have a patient with rheumatoid arthritis, we would give some immune system modulators to calm down, or actually calm down the immune system that's actually very chaotic. So they would be maintained on those particular medications. Some of the medications you might probably be familiar. They're called DMARDs, and one of the more common ones is methotrexate.
Oh, okay. All right. So it's really something to calm down the immune system. That's what you would give someone with rheumatoid arthritis. Would you also include pain medications?
Oh, yes. Again, yes, we have to address the symptoms of the patient. We have to address the current inflammation of the patient. So, pain medications like your paracetamol, anti-inflammatories like your NSAIDs, your steroids will also be part of our armamentarium in terms of rheumatoid arthritis. But that will always be with some other medications, particularly your immunomodulators.
You mentioned the word armamentarium. Is that like arming your...
That's generally armamentarium. Yeah, your medicines.
Yeah. I think I have an armamentarium of sorts, but yeah, I like that. First time I've heard that word used, and sounds like, oh, the weapons against the illnesses or the pain.
Exactly.
That's great, doctor. I learned a new word today from you. I would only learn it. I wouldn't have learned it if I did not do this show or meet you. So this is fantastic. Okay. And then, okay, do you ever give patients like who are in too much pain? Do you ever give them narcotics? Has it gotten to that point? Narcotics, or they get hospitalized for pain alone? Can you talk about?
Yes, there would be some patients who would have severe kinds of arthritis, severe osteoarthritis, or any other kinds of arthritis that would cause an excruciating level of pain. Narcotics would still be an option, but it's actually down the line. We have to try out the first few. We have to address it step by step. But narcotics, it's still part of our medications, but that is if we've already tried or exhausted the first few ones already.
And okay, we didn't quite, if you can talk a bit about the physical therapy part for arthritis in general, because we didn't quite get into that, because I wanted to ask you about the medicines and the armamentarium. The physical therapy part, how is that done? Is it individualized? Like, do they have to go to the hospital? Can people go to patients' homes?
Yes. Yes. So generally, for some kinds of arthritis, well, particularly if we have osteoarthritis, for some other like rheumatoid arthritis with certain in certain cases, ankylosing spondylitis, which is another kind of arthritis. Those are very much would have physical therapy a very big part of the management. Why? Because we want to maintain, or at least we want to maintain the tone of the muscle. We have to maintain the range of motion of the joint. We have to maintain also the movement, or generally the health of the whole joints and also the muscles. And that's actually with the help of your physical therapy. Physical therapy, yes, it can be done in the hospital. It can be some physical therapies would also do offer home services. But before going there, we have to ask the help of our rehabilitation medicine doctors, our rehab med doctors. They would be able to prescribe a very specific physical therapy regimen plan for each patient. So it is an individualized therapy or regimen, and then they would actually also connect to the physical therapies. The physical therapies will eventually do the regular therapy sessions.
And then, doctor, so in terms of this prescription for the patient, so the rehab doctor would be aware that it's arthritis and would know exactly, like, are you involved at all in the prescription of the plan?
Yes. Okay. So usually how I would do it is actually I would refer a patient to a rehab doctor. When I do a referral, I make a letter or a form of communication stating what's the rheumatologic disorder of the patient. For example, a patient with severe osteoarthritis of the knees. So I'd put there, I'm referring this particular patient for co-management, particularly rehabilitation management, because the patient has severe osteoarthritis of the knee. The rehab doctor would then know what things to do, mainly what their goals are. If these are to improve the flexibility, the range of motion, to improve the muscle tone of the muscles around the knee. So those are their goals. And in order for them to achieve those goals, they'll be doing a dedicated, individualized regimen for that particular patient for the physical therapies to do.
Okay, that's okay. So that is just you. So to someone like, I think I remember Dr. Toby. So okay, so there. So you are involved in it, and you basically the main information comes from you, and the rehab doctor would know what to do, and you do communicate with each other throughout the process as in terms of the progress of the patient.
Yes.
And it can be done in the hospital, in house, or for some who might prefer a physical therapist at home. Those things are kind of easier to figure out if that's part of the management. How about basic things, doctor, like if it hurts, can you put warm compress? We have all these things. Is warm compress is it recommended, or is it cold compress? Sometimes we know when we get injuries, cold compress first and warm, but like what other things can we do to manage the pain at home?
It depends on what kind you're trying to treat. For example, you have an inflamed joint, mainly caused by, for example, gouts there. What you would like to put for the patient to put is ice compress, because that would help the inflammation or to lessen the inflammation. If we're talking about the stiffness that the patient feels, if you have, like, for example, osteoarthritis, you would feel a little bit of stiffness in the morning. Usually, when you get up from bed, your knees get to stiffen or your hands get to stiffen. Putting a warm compress there would actually help it. But probably the dictum is, if the joint is maga or is inflamed, what you have to put is ice compress.
Yes, because it will, okay. And people ask, why won't it hurt more? But doctor, why cold versus hot compress?
For particularly for inflamed joints, it actually alleviates and helps the inflammation. Yes. So remember, it might actually be medyo masakit kasi malamig, but in the long run, it would actually help the inflammation.
Yes, okay. Kasi you need to yeah, okay. And thank you, doctor. At least galing sa'yo na. Sana one of my friends is listening will finally listen. It's not me explaining anymore. It's really the doctor. And then, okay, 2 quick questions. What do you think of massage? In massage for arthritis or people who have pain, like massage or reflexology or anything, basically that kind of remedy when it really hurts, they want their muscles massaged or maybe even that part massaged. What's your take on that?
Massage should, well, I don't have any problem with the massage, but maybe not during an attack, because it might actually, remember, a swollen joint is a tender or painful joint. So when you do massage it, it might actually cause more pain for the patient. So it might actually be counterproductive at the end of the day. But I don't have a problem if they feel that it's helping their muscles, it alleviates the pain, a little massage here and there should not be a problem. Probably the manipulation of your joints, cracking of your back, that's probably, what we probably would refrain or shy away, because those are special techniques and maneuvers that might be harmful if not done properly.
If you crack your fingers, is that bad from your point of view?
Generally for the fingers, it's not really that particularly significant. What I'm talking about, or at least what we're fearful about, is the back. doing the manipulation, tracking, the ones that you see in TikTok, in Facebook, people offering tracking services. Those are things that we tend to shy away from.
And they may not completely know what they're doing unless they have the right credentials. What do you think of chiropractors? Ooh, should I not ask you that? Let's not go there. Never mind. Okay. So yeah. Okay. Thank you, doctor. What happens if you leave arthritis untreated? For those who say, it's okay, I can take the pain or I'll just manage. What can happen? What's the downside of not treating it?
Well, it depends on what kind of arthritis. If it's gouty arthritis, if we don't manage it, it would actually be more it would complicate. It would actually cause some deformities in your joints. It would also cause some uric acid deposition. The ones that you see in some patients, they would have little parang bukol na namumuti over their joints. Eventually, they won't be able to use their hands and their extremities anymore. Other complications, they might have also some kidney problems, kidney stones along the way if you don't get to manage it. For osteoarthritis, if we don't get to manage it, and we don't address other or modify lifestyle, weight, etc., it will actually progress and will cause us more pain. For rheumatoid arthritis, yes, it will also destroy the joints, the bones at the end of the day if we don't get to manage them.
Is there anything, Doctor, we're actually running out of time for this show. Is there anything you'd like to say, or anyone you'd like to greet, and then anything you'd like to say to the audience as final words on the topic arthritis, or any topic you'd like? You have the floor.
Thank you for inviting me today. Thank you for letting me share basics about arthritis. I know arthritis is such a big topic. It has a lot of branches under it. But what I could probably advise patients is that if you feel any pains, joint pains, don't feel free to consult your friendly rheumatologist. They might ask a lot of questions. They might do some examinations, and hopefully with those, we'll be able to help you more in terms of what kind of arthritis you have and how it should be managed.
Okay, doctor, I'm going to ask for your number privately. You don't have to say it in the show, but please send it to me because I will consult my friendly rheumatologist. I will. Thank you very much, doctor. Is there anyone you'd like to say hi to or anything?
Probably plug lang po. Maybe you can go to Makati Medical Center has a vast number of rheumatologists in our section. So you could feel free to consult any one of us. We're friendly enough, I think.
And with each other. Oh, yeah. Okay, that's great, doctor. Thank you for being on the show. It's my pleasure. I mean, I learned armament. What can you say it again?
Armamentarium.
I learned armamentarium today, and aside from that, so much more about arthritis. And I really do hope that this show reaches the people that need to hear it and that it can help. And thank you for being on the show, sharing your precious time, your precious information, your energy, and your effort with all of us. Thank you, doctor. And for those who are viewing or listening, we'll be back next week on Monday, 5 to 6:30 p.m. This is Healthline with Makati Med. I'm your host, Nicole Jacinto. Our guest is Dr. Estrella, your friendly rheumatoid arthritis specialist. Take care, guys. We'll see you again next week. Bye.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of health.